All right, so what we're going to talk about is really how are we doing things out in the real world. And I don't have any disclosures. Here we go. I will say that the quick and dirty of the learning objectives is that I want people to be aware of what our colleagues' organizations are saying. So when you're thinking to yourself, why is my obstetrician doing this way? Or you're wondering, why won't my labor nurse do what I'm asking her to do? This is where that comes from. And then we'll throw in a little bit from the most recent workforce survey, which has been submitted for publication, and you'll see more about shortly. So let me start with one of my favorite quotes having to do with obstetric anesthesia. This is an obstetrician talking, and he says, "The removal of a brain tumor in an elderly patient calls for a surgeon who has 2 assistants, a scrub nurse, 2 circulators, an anesthetist, and an assistant. Patient's prognosis is about 18 months, and the hospital investment is tremendous." In contrast, the birth of a new baby at 4 a.m. is more often attended by 1 physician, no scrub nurse, a circulator, and inadequate or haphazard anesthesia coverage. As a profession, we seem to be committed to the fallacy that to be interesting, one has to be an adult, fully developed, and preferably degenerating. And we've all seen it, right? Labor and delivery is often the poor stepchild of the main OR, and we get the hand-me-down everything and sort of staff it as best we can as long as the OR is covered, et cetera, et cetera. So what that adds up to is the fact that there's a lot of problems with running a labor and delivery service. So I don't know if you're aware of this, but the American Society of Anesthesiologists has a consultation program. It's been in existence for 30 years now, so they've collected a lot of data. And the way it works is that either an anesthesiology group or the medical staff office at your hospital or the administrators at your hospital can call the ASA and say, "We're having some trouble here. Can you come in, send a surveyor, take a look at our practice, and give us some recommendations for what we should do?" Now, this comes out of the ASA's Quality Management and Department Administration Committee, or QMDA, as it is fondly known. So let me just show you some of the major issues they've come across when they've come in to evaluate these hospitals. This is, like I say, about 30 years worth of data, and you can look down, you can see things like department leadership and quality assurance and MD competence and organization, and then all of a sudden, boom, there's obstetric anesthesia. So almost 50% of their consultations, somewhere in there was the hospital going, our OB anesthesia service just isn't running well. Now, do you see cardiac anesthesia on there? Do you see pediatric anesthesia? Do you see pain management? Do you see any of the other things we do? No. There's something about obstetric anesthesia that's difficult. So why is that? Why is L&D so tough to cover? Well, unpredictable cases. You don't get a schedule for what's going to be happening that day. It's around the clock, so you're just as likely to be busy at 3 a.m. as you are at 3 p.m. We have a lot of requirements on us to provide immediate availability to this service. A1 guidelines limit how the nurses can help you, and we'll talk about that in just a minute. There's not good standardization of drugs and techniques. We are like herding cats. Every single one of us has our own preferential way that we like to do it that's probably different than our partners, is definitely different than the other hospitals in town. And the hospitals themselves often stated that the MDs didn't provide adequate medical direction of CRNAs or AAs, especially if it was an emergency or if it was after hours. So these are kind of the problems we face. And because of that, there are a lot of guidelines out there having to do with obstetric anesthesia that you may want to incorporate into your practice if you're trying to set up policies for your unit. So I'm going to talk about ACOG guidelines, A1 guidelines, and a little bit about ASA guidelines. Now you can see the ACOG website there. Probably their main publication that we're used to seeing are the guidelines for perinatal care, which has had multiple editions. The good thing about it is that the parts that have to do with anesthesia, they use the liaison from ASA to ACOG to help write that. So we definitely have input. ACOG is very accepting and would really like us to have input into the things that they're doing. But let me talk about the VBAC guidelines specifically. So a number of years ago, ACOG came out with guidelines for the woman who's having a trial of labor after a C-section or a TOLAC in the hopes that she will have a vaginal birth after her cesarean or a VBAC. So The VBAC guidelines specifically said if a hospital is going to offer trials of labor, they had to have immediate availability of anesthesia services, of OB services, of a nurse, of an operating room to put that patient in, so if her uterus ruptured and there's a big emergency, everybody could be there. And in the years since then, C-section rates gone up and trials of labor have gone down. So, concerned about this rising rate of cesarean delivery, the NIH convened a consensus conference, and you can see two of their recommendations there. First off, they say both trial of labor and an elective repeat C-section have risks, but maternal mortality is significantly higher after an elective C-section. I think we sometimes get that turned around in our head, but in the big scheme of things, you're more likely to die from your elective repeat C-section than you are from your trial of labor. Second thing they said is ACOG's immediate availability statement within the guidelines may have forced a lot of women to undergo a riskier procedure because they weren't offered a trial of labor or it wasn't available at the hospital where they're going to deliver. So the conclusion was you need to address the barriers to trial of labor after C-section that ACOG had put in place. The other piece of it, not covered here, but we sometimes think that a C-section is safer for the baby because we save it from some stress of labor, and that's actually not true either. If you compare neonatal outcomes after an elective cesarean versus after a vaginal birth after cesarean, NICU admission rates are higher. Perinatal mortality, although very low, is still higher in the C-section group, and it's more expensive to do another C-section than if a woman can have a vaginal delivery. Now, it's true that uterine rupture is more likely to occur during a trial of labor than if you have an elective C-section scheduled, but again, vanishingly low numbers, a very, very rare thing. So both mom and baby do better if you can have a vaginal delivery after your prior C-section than another C-section. Okay, so based on all that, ACOG did indeed go in and revise their practice guidelines. The new version came out a couple years ago. And these are some points out of it. One is that several factors increase failure rates, so you need to tie your specific patient counseling to that one patient. And there's now algorithms online. You can go in and plug in that woman's information and give her an actual number of your chance of having a successful vaginal delivery is 70%. Or it's 30%, let's not bother, we're going to go ahead and do your C-section. So it lets you stratify risk and help that woman decide what she wants to do. Second thing they said is women with 2 prior sections can now labor. That used to be a no-no, that's now okay. And women with twins, as long as they've had 1 prior section, can also labor. If she has a breech presentation and would like to labor, you can do a version, even though there's a scar on that uterus. And you can also induce her, although they recommend against misoprostol or Cytotec for induction, because that has been associated with increased risk of rupture. And finally, they do stick to their statement that says a trial of labor should be done at facilities capable of emergency deliveries, meaning all of us can be there, boom, drop of a hat. But they go on to say when these resources are not immediately available, respect for patient autonomy supports patients should be allowed to accept that increased risk after they've been counseled. So if everybody's on call from home in your hospital and this woman is adamant that yes, she understands that, but she wants to go ahead with her trial of labor, ACOG's saying, okay, she should be allowed to do that, it's her choice. I'll let you interpret that as you will. So one of the things that was asked in the most recent workforce survey, which if you haven't seen these before, every 10 years since 1981, survey hospitals all around the country and ask them, how are you practicing? What do you do in your practicing? And then it's stratified into larger delivery hospitals, smaller delivery hospitals. So the question here on the survey was, does your hospital allow trial of labor after a prior cesarean delivery? And you can see that the percent decreased across all sizes of delivery services, especially the smaller ones. So this became kind of busy, but where it says TOLAC allowed, in the first one, the larger delivery services, over 1,500 deliveries a year. In 2001, 98% allowed it. 2011, only 92%. But look at the smaller deliveries. In 2001, 68% of them allowed a trial of labor. Now it's only 48%. The other question was, do you require the anesthesia team to be in-house if a woman's having a trial of labor, regardless of whether she's got an epidural or not? That's gone up, surprisingly. So especially in the smaller hospitals, you can see 10 years ago, 33% made anesthesia stay in-house. Now it's up to 61%. And OB required to be in-house kind of matches what we're doing, which that makes good sense. Hopefully that will occur. So I would say across the board, fewer hospitals are offering a trial of labor. Unfortunately, we haven't made a dent in that, but we're more likely to be staying in-house if the woman's attempting a VBAC. So what do we do with all this? I think anesthesiologists, obstetricians, were really struggling with how do you staff that, especially if it is a small delivery services. How do you bill for availability if we're in-house and she doesn't ever want an neuraxial block? Can you get paid for that in any way, shape, or form? If your hospital doesn't offer trial of labor, where do you refer her? Where do you send her? Where I practice in Colorado, the hospitals tend to be along the Front Range. So if you live in Steamboat and you want to have a trial of labor, you got to travel to Grand Junction or you got to travel to Denver to be allowed to do that because their hospitals don't do VBACs. But ACOG continues to stand by its guidelines. They're saying this is what's safe, this is what's right, this is what people ought to be doing. And now JCO has also incorporated the ACOG guidelines into their standards as well. So what does that mean? I don't know. We're kind of out there with the whole trial of labor thing, and if you're in a small practice, you're going to have to sit down and discuss with your obstetricians how you think that ought to be handled. The other ACOG guidelines have to do with maternal comorbidities, which we're, of course, going to be involved in. If there's a sick mom, anesthesiology needs to be there and involved in her care. And we've talked endlessly about hypertension over the last few days, but I did just want to point out two things. One is that this study looked at if a mom has underlying comorbidities, how do they contribute to her risk of mortality? And you can see if she has preeclampsia or chronic hypertension, she has an 8-fold increased risk of maternal death. So that's the big one out there in terms of what's going to get her into trouble. So ACOG has this committee opinion, it's a mouthful, it's called the Emergent Therapy of Acute Severe Hypertension with Preeclampsia-Eclampsia. But the reason I want you to see it is because it involves us. We are specifically named. So what it talks about is the fact that hypertension over 160 systolic should be considered a hypertensive emergency, just like Dr. Drusen talked about yesterday. People need to be at the bedside, giving drugs, get that pressure down now, because what she's going to die from is a bleed in her head. Pregnant women with preeclampsia don't auto-regulate well, and so they can have a cerebral hemorrhage at a much lower systolic hypertension that you might think. So they go on to say you should try vilobetalol in escalating doses, IV hydralazine, but if those don't work, get an emergency consult from an anesthesiologist. So we in front and center is the person who, once they've tried their armamentarium of 2 things they know to do, they're calling you. And then we need to come in and step it up and figure out how to get this woman's blood pressure under control. The other big cause of death in pregnancy is clotting, thromboembolism. So ACOG's being very, very aggressive about prophylaxis, especially after C-section and anticoagulating high-risk patients. So you can see here that embolism is the second leading cause of death after cardiovascular conditions. So they have a practice bulletin about management of, or prevention of thromboembolism, I guess you should say. And the important thing for us to know is the ASRA guidelines are in this ACOG practice bulletin. So they go in there and they talk about, 12 hours after a prophylactic dose, 24 hours after a therapeutic dose of anticoagulant, that you need to wait for 2 hours after the catheter is pulled before you give the next dose, etc. All that is in there. So your obstetricians have already been presented with our guidelines that are going to affect how we do neuraxial anesthesia. They also go on and talk about women having a C-section need to get prophylaxis of some variety all the way up to potentially heparinization. And our role in these patients is certainly getting them comfortable enough that they ambulate quickly. So good post-op pain control after their C-section, like Dr. Carvalho talked about yesterday. And then finally, fetal neuroprotection, which Dr. Wong mentioned the other day. This is their committee opinion that addresses this. So It's been shown that magnesium before an early preterm delivery will decrease the risk of cerebral palsy if that baby survives. Doesn't affect death rate, but if that baby's going to survive, it will reduce its risk of having cerebral palsy. So the algorithm includes a fetus who's between 23 and 32 weeks who's going to deliver within the next 12 hours. That's a pretty small subset, really, when you think about it. It's not like we're going to see this a lot, but we will see it. So they get a 6-gram load over 30 minutes and 2 grams an hour for 12 hours until they deliver. And there is an economic analysis goes along with this showing that you do indeed get lower costs by treating these fetuses this way because there's better newborn outcomes. So again, knowing what ACOG guidelines are out there, how they're instructing obstetricians to manage these things, I think is important to us so we sort of get it, how they're thinking and why they're doing what they're doing. So let me move on to A1. If you haven't run into A1 yet, this is the Association of Women's Health Obstetric and Neonatal Nurses, and they are the trade organization, I guess you would say, for our nurses who work with us on labor and delivery, in the nurseries, and actually also with the GYN patients. And they have been a tough crowd to deal with. They don't collaborate well. So if you go to their website, which is a1.org, they have this guideline that affects us. Again, another mouthful. It's called the role of the RN in the care of the pregnant woman receiving analgesia anesthesia by catheter techniques. I will point out that no physician group has endorsed these. So ASA, SOAP, ACOG, AMA have all been presented with this document and declined to endorse it. AANA has, and also the critical care nursing organizations have. So what the guidelines say is that the L&D nurse cannot change or manipulate PCEA settings, initiate a continuous infusion, meaning hit the on button on the pump, adjust the infusion rate. So if you call her from the OR and say, Miss So-and-so's having breakthrough pain, can you bump her infusion up from 10 to 12? They will say, nope, can't do that. They can't bolus from the pump. They cannot administer some kind of pre-prepared epidural bolus that might come from your pharmacy. So there's a lot of things your L&D nurse can't do with your epidural infusion. Now, ACOG, ASA, SOAP have all protested this for the last 10 years, probably. Talk about beating your head against a brick wall. And the kind of arguments being made are that, one, there's no morbidity mortality data out there to show that any of these things are dangerous for the patient. It does not allow for variations in nursing education at different hospitals. I'm not saying every L&D nurse needs to be out there playing around with our pumps, but if you have educated them, you have a protocol in place, you've drilled them on the safety features, et cetera, no reason they can't do this. They certainly administer other dangerous medications that can harm a patient, like magnesium, oxytocin infusions. We give IV fentanyl all the time. And the concern is that patient care and satisfaction are going to be impacted if the nurse can't help us. So, as I say, we have argued and argued and argued with A1, sat in their offices for hours, tried to get them to say, you have no evidence to do this. Why are you making these claims and getting in our way? And they, thus far, have not budged. Okay, so the rebuttal specifically, and you can go on the ASA website and copy this letter. You can also see the joint SOAP ASA letter that was sent to A1. But what it says is that ASA and ACOG believe women requesting anesthesia services during labor should not be deprived of these services based on inadequate nursing participation in the management of labor anesthesia modalities. So in an effort to allow the maximum number of patients to benefit from neuraxial labor anesthesia services, ASA and ACOG believe labor nurses should not be restricted from participating in the management of pain relief during labor. If they have appropriate physician supervision, they've been trained, they've demonstrated competence, they should be able to participate in the management of epidural infusions, including adjusting dosing and discontinuing infusions, just like they do out on the floor with our pain patients. So realize that that doesn't affect that part of our practice. This is specifically the labor and delivery patient who has an epidural. So how has that affected things? Again, if you look at the workforce data and just say, what's PCEA use done during the time we've been dealing with these ACOG guidelines, it has jumped up dramatically. So in the larger delivery services, 82% now use PCEA, 35% back in 2001, 10 years ago. And even in the smaller hospitals, 53% use PCEA versus 18%. which means that since the nurses have decided they can't dose the patients for us, we're going to let the patients do it all by themselves because that is somehow safer. But nonetheless, if you're running into that problem in your practice, PCEA may be a way around it to help you out. If you can't see this, it says, you know what they say, what doesn't kill you only makes you older. So 10 years later, I'm 10 years older and I still haven't been able to make a dent in the A1 group. Okay, so last but not least, these are the ASA guidelines that have to do with obstetric anesthesia. Some of them are letters, some are guidelines, some are actual practice advisories. But again, you can go on the ASA website. Once you get there, click on publications and services, and then under that, you'll see standards, guidelines, and statements. And I'm just going to talk briefly about a couple of these. I think one of the more common questions people have, and especially if you work in a rural area or a small hospital that doesn't do a lot of deliveries, is people will say, well, isn't there some ASA guideline that says you have to stay in-house after you put in a labor epidural? And the answer is no. There is nothing in writing out there that says that that is a requirement. What the guidelines actually say is that because the availability of anesthesia resources may vary, it's the members who are responsible for interpreting and establishing the guidelines for their own institutions and practice. So what's going to happen in your hospital if you have 300 deliveries a year is very different than what's going to happen in someone's hospital who does 7,000 deliveries a year. And ASA is not going to try to have some global thing that's going to cover everybody. It's specifically Guideline 8 within that document that deals with this, which says a physician with appropriate privileges should remain readily available, that's the exact wording, readily available during the regional anesthetic to manage complications until she's safe and sound in the PACU. So readily available, again, is what's up to your group, your hospital, to interpret what that means. Does that mean you're at home because you live 5 minutes away from the hospital? Does that mean you can't go down to the OR to do another case because you have a patient laboring? That's for your group to decide what that means. So I do think this brings up some other thoughts and questions about how you might manage this. So for example, if you put in a labor epidural, can you go down to the main OR and do an appendectomy at 2 in the morning? While that epidural's running? Are you still readily available in that situation? Can you do 5 or 6 labor epidurals and have them all running at the same time? Can you put in a labor epidural and then go do a C-section where you're going to be tied up in the OR? Can you go home if you can be back in less than 30 minutes or whatever your group's decided the amount of time should be? And how's this different from the way we manage our post-op pain epidurals? If you have an 80-year-old with a thoracic epidural running after their AAA repair, do you stay in the hospital and sit by the bedside with them? So why do we do that with our healthy 20-year-old who's laboring with an epidural in place? And finally, are single-shot intrathecal narcotics somehow different than local anesthetic infusion? So if your practice is to do a single injection spinal intrathecal fentanyl bupivacaine, can you go home versus an epidural infusion that's running? So I'm not giving you any answers to any of this, okay? This is not any kind of black and white subject that you can just go yes, no, yes, no, yes, no down. But I think you have to think about within your group, your practice style, your geographic area, how do you want to handle these different things on your labor and delivery service? So in terms of workforce, what are we really doing out there? What is the availability of in-house personnel across the country? Well, it's getting better and better, actually. So if you look at the over 1,500 births a year group, in 2001, 80% of us were in-house. Now it's 90. If you look at the small hospitals, less than 500 births, only 3% of us were in-house 10 years ago. Now it's up to 16. Percent on call is the reverse of that, obviously. So in the small hospitals, about 84% of people take call from home. So that's not an unusual thing. It's actually fairly common in these small delivery services. And the good news is nowhere is labor analgesia unavailable. So in terms of what's available for our moms and making them comfortable and providing neuraxial anesthesia for them, it's getting better and better. Now, I did want to mention these practice guidelines for, again, another mouthful, prevention, detection, and management of respiratory depression associated with neuraxial opioid administration. This is our morphine guidelines, okay? If you use spinal or epidural morphine, this is where your policy comes from for how your patient needs to be monitored for the next 24 hours. And I did want to bring up one point, which there in the document it says continual epidural opioids are preferred to parenteral opioids for anesthesia and analgesia because they reduce the risk of respiratory depression. Now, isn't that interesting? For the longest time, we thought spinal and epidural morphine were more risky, and we had to have this heightened awareness, and our patient was more likely to get in trouble than if we just handed her a PCEA button, and that is not true. So specifically, the way these guidelines are organized is there's an identification section, and specific to the OB anesthesia piece of it, because this covers everything, acute pain, chronic pain, everything. The things that we'd want to worry about were our patients with obstructive sleep apnea, obesity, if they're on medications like mag sulfate that might already make her hypoventilate. Prevention, specifically our OSA patients should have their CPAP mask available and be able to use it. Detection of respiratory depression, here's what they say about neuraxial morphine specifically. Monitoring should be performed at least once per hour for the first 12, every 2 hours for the next 12. So that's how your guidelines ought to be written for how your patients are monitored after their neuraxial morphine, in terms of nursing, monitoring of sedation, respiratory rate, et cetera. And then you should have treatment options available if your patient does have respiratory depression, like reversal agents, naloxone. Finally, they say that all patients receiving neuraxial opioids should be monitored for adequacy of ventilation. This does not mean a pulse ox, okay? Every patient who got spinal or epidural morphine does not need to be on pulse oximetry for 24 hours. The guidelines simply say you should look at oxygenation somehow, might use a pulse ox if that's available and you think it helps you, but it is not mandatory for patients who've had these drugs. So you have to monitor, but it doesn't specify what you should be doing. And nursing assessment is probably the most common thing across the board that we use. So, little breather here, and then the last thing I wanted to cover in the last few minutes are the actual practice guidelines for obstetric anesthesia from the ASA. So these were last revised in 2007. And I wanted to mention how they're put together only because I think people sometimes misinterpret where in the heck do these things come from, these people are telling me I have to do. Well, they're evidence-based if we have evidence, but face it, we often practice the art of medicine, right? As much as we do the science of medicine. So in order for the guidelines to say the literature supports something they're telling us to do, you have to have 5 randomized controlled trials that can be combined into a meta-analysis. We don't have 5 randomized controlled trials on very many things in obstetric anesthesia. So more often we go to the second thing, which is you get a group of consultant experts together, and usually there's 50 to 100 people that have been pulled into that pool, and then they ask them, what do you do in your practice? What do you think is the right thing? These guidelines deal with patient care stuff. It's not do you have to be in-house or not. This deals with do I need to draw a platelet count? So these are the clinical guidelines. These are the areas they cover. So pre-op evaluation, aspiration prophylaxis, L&D care, how do you do retained placenta cases, choices for C-section, tubal ligation, and then finally the emergencies like difficult airway, hemorrhage, cardiac arrest. So those are the different sections in the guidelines, and I just want to show you 2. First off, in the peri-anesthetic or pre-op evaluation section, these are the recommendations within the guidelines. You need to look at the airway, listen to the heart and lungs. Pretty simple stuff. You need to have a communication system in place so the obstetrician or the labor nurse will come to you and say, I'm worried about this. So if you haven't set up that kind of communication that your obstetrician thinks it's okay to come to you and say, you know, her systolic blood pressure is over 180 and I'm not comfortable giving any more hypertensives, they can come to you. Or if the labor and delivery nurse feels like, I just don't like the way she looks, I don't know what's going on here, they'll come find you and say, can you come look at this with me? Third is routine platelet counts are not necessary, and I'll show you what the workforce survey shows. Don't type and cross routinely, type and screen only by risk factors, and you should do fetal heart rate monitoring before and after, but you might not be able to do it while you're placing the block. So what do we actually do with the platelet count thing? And I mentioned this on Friday. Do you require a platelet count prior to placement of labor analgesia? Even in the big delivery service, half of us still do. I don't know why that won't stick, but again, you don't need to draw a platelet count before your routine healthy patient having a labor epidural. And then finally, aspiration prophylaxis, just because people are often like, now, when can they have something to drink? What can they have while they're in labor? Well, the guidelines follow pretty much the overall MPO guidelines. So you can have clear liquids as long as it's uncomplicated laboring patients. If they're having some elective procedure, C-section, tubal, no clear liquids for the last 2 hours. If you have risk factors in your laboring patient, like a horrible airway, horribly obese, insulin-dependent diabetic, bad-looking monitor strip, yes, she should be MPO. You need to pick her out. No solids in labor, period, in the usual 6 to 8 hours before an elective procedure. And then think about giving medications for aspiration prophylaxis as well. And I just want to show you a patient I had a couple weeks ago who walked in with a back that looked like this, saying she wanted her labor epidural. This is actually after we pulled the tape off. You can see it on her back, but I'd never seen this before, the anatomically correct patient. So with that, I will close. Again, we'll have questions with the panel, but I hope this helped you kind of understand how our colleagues are thinking about what we do. Thank you.